Well, welcome back. We're now going to move to the topic of pulmonary gas exchange. And as I pointed out right at the beginning of this series, gas exchange is the primary function of the lung. So we're now at the center of the activity of respiratory physiology, and we're going to look at it in some detail. Gas exchange is very important, not just because of its physiology, because in the clinical situation, it is desperately important. Most of the patients that you'll see with pulmonary problems have impaired gas exchange, and it's very important to understand what's going on. We're going to do this in two parts. The first part today has to do with looking at the overall oxygen cascade from the air to the mitochondria. And then we're going to look at 3 of the 4 causes of hypoxemia. Hypoxemia being an abnormally low PO2 in arterial blood. And these 3 causes are hypoxemia, diffusion impairment, and shunt. And we'll deal with those 3 today. The last cause, which is ventilation-perfusion inequality, will be dealt with in the next session. You may say, why do we devote a whole session to that? Well, there are 2 reasons. One is that it's extremely important because it's responsible for most of the impaired gas exchange in patients, for example, with chronic obstructive pulmonary disease. Secondly, it is a complicated area and not so easy to understand. And perhaps there's a third factor, and that is that it is frequently misunderstood in some aspects. So that's the way we're going to set it up. We're going to deal with the first session today, and then ventilation-perfusion inequality in the second. And the first thing we're going to look at is a perfect lung. This is a hypothetical perfect lung. It doesn't exist, but it helps us to understand the oxygen cascade from the air to the mitochondria in the simplest possible way, and then we're going to look at the various ways in which this perfect situation is impaired by 3 causes of hypoxemia. So here we have our perfect lung, where we have the PO2 of the inspired gas is 150 millimeters of mercury. That's what we're faced with in our environment. Now, just very briefly, you recall how we calculated that. The barometric pressure is 760 at sea level, and we have to subtract the water vapor partial pressure, which is 47 millimeters of mercury at 37 degrees Celsius. So 760 minus 47 gives us 713. And if we take 21% of that, we get 150. So that's how we derive the partial pressure of oxygen in the moist inspired gas, because the gas, when it's inhaled, is warmed and moistened in the upper respiratory tract. So the lung is faced with a PO2 of 150. And in this perfect situation here, I like to draw an analogy with an engineer who's designing a power station with turbines, using water to run the turbines. And let's imagine that he has a reservoir 150 meters above the power station. Now, there's nothing he can do about that. That's the geography that he's faced with. And the issue is, how's he going to get as much pressure as he can to the turbines where the water is going to generate the power? And in the same way as physiologists or physicians, we're concerned about losses in the line from the reservoir, which is the air that we breathe with a PO2 of 150, down to the mitochondria in the tissues. And this scheme here shows the perfect situation, and we'll discuss this in some detail. Now, the first thing you'll see when we look at this perfect lung, as it were, is that the alveolar PO2, to which the capillary blood is exposed across the blood-gas barrier, the alveolar PO2 is only about 100 millimeters of mercury. In other words, we've lost 1/3 of the available PO2 in our movement from the inspired gas to the alveoli. And you may say immediately, well, That seems to be a very extravagant loss. What's the reason for that? Well, the reason for the PO2 of about 100 millimeters of mercury in the alveolar gas is that it's determined by two opposing factors. On the one hand, we have the continuous addition of oxygen to the alveolar gas by the process of ventilation. And on the other hand, we have the continuous removal of oxygen from the alveolar gas by the pulmonary blood flow. Now you may say, well, hold it, wait a moment. Surely ventilation is not continuous. We have a tidal breath in and out, and we breathe 15 times a minute or whatever, so surely that's not a continuous process. Well, it turns out that the tidal volume, as we discussed before, is about half a litre. And this is going into a volume of about 3 litres. So the upshot is that the alveolar PO2 only changes by about 2 or 3 millimeters of mercury with each breath. So we can consider the process as continuous. It's a little bit like driving your car and filling it up every time you pass a gas station. Just top it up, and so the tank is kept at about the same level. You may say with the blood side, surely that's not continuous. The right ventricle is pumping out blood at 60 times a minute or whatever it is, so surely capillary blood flow is not continuous. And that's true. There is some pulsatility in the pulmonary circulation, the pulmonary capillaries, but it's a minor factor, and it's very reasonable to consider both of these processes, ventilation and blood flow, as continuous, and that the net result of this addition of PO2 by ventilation and the removal by blood flow sets the value at about 100 millimeters of mercury. Incidentally, just in passing, this is true of all mammalian lungs. They all have alveolar gas with a PO2 well below the inspired value, but oddly enough, the bird does not suffer from that disadvantage. In the bird lung, the gas exchanging tissue, the pulmonary capillaries, are exposed to the inspired air. This comes in via the air sacs, which pump it through the gas exchanger. So the bird lung is superior in that respect. And as a matter of fact, the bird lung is superior in a number of respects, which I'd love to talk about, but we don't have time to do that, so let's move on. Now, we've said that the PO2 is set at a level of about 100 millimeters of mercury. What about the PCO2? Well, that's set at about 40 millimeters of mercury by the same mechanisms. Of course, in this case, the carbon dioxide is added to the alveolar gas by the pulmonary circulation, and it's removed by the process of ventilation. So it's the inverse, if you like, of the uptake of oxygen, but the same principles apply. The PCO2 under normal circumstances is set at about 40 millimeters of mercury. Now let's look at the first cause of hypoxemia, and that is hypoventilation. And that's a relatively easy mechanism to understand. As we said before, the level of PO2 is set by a balance between the addition of oxygen by ventilation and its removal by blood flow. In hypoventilation, the ventilation is reduced, hypoventilation, and therefore the rate of addition of oxygen to the alveolar gas falls. As a matter of fact, the CO2 production and the oxygen consumption of the lung are pretty much set at the normal levels at rest, and there's not much you can do about it. So the oxygen level and the CO2 level are normally 100 and 40 respectively, and hypoventilation, as we can see, because it reduces the level of ventilation, is going to reduce the PO2, in this case down to about 60 millimeters of mercury. Well, just as hypoventilation reduces the level of oxygen, so it increases the PCO2 in the alveolar gas. And the first question we might ask is, well, how far does the PCO2 change in hypoventilation? And we've actually looked at this before, but it doesn't hurt to just review it again. This is the alveolar ventilation equation, which relates the level of alveolar ventilation to the PCO2. And just to remind you, the alveolar ventilation equation is derived from the fact that all the expired CO2 comes from the alveolar gas. And so if we look at a tidal volume here, expired tidal volume, all the CO2, represented by the dots here, is coming from the alveolar gas. No CO2 comes from the dead space, because at the end of inspiration, the dead space contains the inspired air. There's no gas exchange in the dead space. That's why it's called a dead space. And when that gas is exhaled, of course, it has no CO2 in it. So all the expired CO2 comes from the alveolar gas. And therefore, we can use that statement here, all the expired CO2 comes from the alveolar gas, and we can write an equation. The volume of CO2 per unit time, V dot CO2, is equal to the alveolar ventilation times the proportion of that made up of CO2. In other words, there may be 5% of CO2, so 5% over 100 is the amount of CO2. And we call the percentage over 100 the fractional concentration. You'll remember, we talked about that. And so we can rewrite this equation here as V dot CO2, the CO2 production, is equal to the alveolar ventilation times the fractional concentration of CO2. Now, we also discussed earlier the definition of partial pressure, and the partial pressure of CO2 is given by the fractional concentration times a constant, having to do with the barometric pressure. So we can change, we can take out this FCO2, replace it by PCO2 over K, and that gives us the alveolar ventilation equation. Alveolar ventilation equals the CO2 production divided by the PCO2, and there's a constant here that we don't need to worry about. I'm not going to go into the constant. It has to do with the fact that we measure CO2 production and alveolar ventilation in slightly different units. Let's not worry about it, because we're not going to use the constant at all. It's just important to know that there's an inverse relationship between the alveolar ventilation and the PCO2. In other words, if we double the alveolar ventilation, we halve the PCO2. If we halve the alveolar ventilation, we double the PCO2. And this assumes that the CO2 production is constant. As I mentioned a minute or so ago, under normal conditions, there's not much you can do about the CO2 production at rest. Of course, on exercise, it increases. But at rest, it's fixed by the CO2 production of the tissues, the metabolism of the tissues. Got nothing to do with the function of the lung. It's what the tissues are producing. And there's essentially no way we can change it. Well, we can cool a patient during surgery on the heart. That's sometimes done to reduce metabolism, but you know, that's a pretty dramatic thing to do. And under normal conditions, the CO2 production remains essentially normal, and therefore this inverse relationship between alveolar ventilation and PCO2 is a solid fact. Incidentally, we're going to be using the alveolar ventilation equation extensively, so make sure you're clear about it. One of the nice things about this equation is it's so simple. And if you're faced with some sort of question about gas exchange, the first thing that should go through your mind is, can I use the alveolar ventilation equation to help to solve this, because it's so simple. Well, now let's turn to oxygen. We've seen that we can easily predict the level of PCO2 from the change in alveolar ventilation, because they're inversely related. But what about the level of oxygen in the alveolar gas as we change, for example, the level of ventilation, in particular with hypoventilation? And here we're going to be introduced to another equation which looks rather formidable at first, but really is not complicated, and that is the alveolar gas equation, which is shown here. What the alveolar gas equation says is that the alveolar PO2 is equal to the inspired value, which of course breathing air at sea level is 150, minus the PCO2 over a thing called R. R is the respiratory exchange ratio. Now, the respiratory exchange ratio is the ratio of CO2 production to oxygen uptake, and it's often called the respiratory quotient when we're dealing with metabolism of tissues, the same thing. But at the mouth, it's the respiratory exchange ratio. of course, under steady state conditions, the exchange ratio will always equal the respiratory quotient. But there can be non-steady state conditions, for example, during hyperventilation, where the respiratory exchange ratio, this thing R here, changes temporarily, but of course under steady state conditions it comes back. And finally we've got a small factor R at the end, which we're generally going to neglect. The reason is that it's only worth 2 or 3 millimeters of mercury with somebody breathing air, and so it's a relatively small effect, and we're going to, as you'll see, we're going to be ignoring it, generally speaking. So let's use this alveolar gas equation to calculate what the alveolar PO2 is under normal conditions. And here we have it here. The alveolar gas equation, as we said, was the alveolar PO2 is equal to the inspired value minus the PCO2 divided by R, with a small factor we're going to ignore. So the PCO2, we said, under normal conditions is 40 millimeters of mercury, and it turns out that the normal respiratory exchange ratio at rest is about 0.8. It varies a little bit, 0.8, 0.85, but let's take 0.8 as a ballpark value. So you can see that if we divide 40 by 0.8, we get 50 millimeters of mercury, and therefore this says that the alveolar PO2 is equal to 150 minus 50, and that's 100 millimeters of mercury. So that's a nice way of seeing that the normal PCO2 is 40 and the normal PO2 is 100 millimeters of mercury. Now, what happens to the PO2 in hypoventilation? Well, let's look at the next image here. Here we've got the hypoventilation situation. Again, the alveolar gas equation. Alveolar PO2 is equal to the inspired PO2 minus the alveolar PCO2 over the respiratory exchange ratio. Let's neglect the R value there. And so if we have hypoventilation, let's assume that the ventilation falls to half of its normal value, the alveolar ventilation is halved, then the PCO2 will double from 40 to 80. So the equation now is that the alveolar PO2 is 150, which is the inspired value, minus 80 over 0.8. 80 over 0.8 is 100, so the alveolar PO2 is 50. So what that means is that during hypoventilation, if you halve the alveolar ventilation, the PCO2 doubles from 40 to 80, the PO2 goes from 100 to 50. You'll notice that the PO2 falls a little bit further than the PCO2 rises, and that's because the respiratory exchange ratio is 0.8. If the R value was 1, the fall in PO2 would be exactly the same as the rise in PCO2. Now here's an interesting little problem that we're going to solve using our alveolar gas equation. And the problem is this. Suppose we have a patient with a reduced alveolar ventilation. The alveolar ventilation is halved, and therefore the PCO2 is 80. The PO2 is 50, as shown here, but we'd like to restore the PO2 to the normal value of 100 by giving an enriched oxygen mixture to breathe. The question is, how much, what concentration of oxygen do we have to give? Nice little problem. So let's look at how we can solve that. What inspired oxygen concentration is required to return the alveolar PO2 to normal when we've halved the alveolar ventilation? Well, again, we've got the alveolar gas equation here, and what we want is a PO2 of 100. In other words, what we're asking is, how do we return the alveolar PO2 from 50 to 100? So the inspired PO2 now is not known. That's going to be changed by giving the enriched oxygen mixture, but the PCO2 is 80 over 0.8. And so if we solve this equation, you can see that this thing here is going to be 100. So the inspired PO2 is going to be 100 plus 100, or 200. So in other words, the answer is, on the way to the answer, we've calculated that the inspired PO2 has to be 200 millimeters of mercury. How do we get an inspired PO2 of 200? Well, we use the equation that we've already talked about, that the PO2 is the fractional concentration times 713, because remember, we're dealing with moist inspired gas, so we have to subtract the 47 from the 760 millimeters of mercury, giving us 713. So now we simply solve that equation. FiO2 is PiO2 over 713, which comes out to 0.28. So the answer to the question is, if we give an inspired oxygen concentration of 28% instead of 21%, we can return the alveolar PO2 to the normal value of 100 in spite of the ventilation being reduced to half of its normal value. Now that's a very interesting finding, isn't it? Because what it means, it's very easy to increase the inspired oxygen concentration by 28%. I mean, normally it's 21. All we're doing is raising the oxygen concentration by 7%. It's dead easy to do using cannulas in the nose or a mask or something like that. Very easy to do that. So what this means is that it's very easy in practice to overcome the hypoxemia caused by hypoventilation by giving the patient some oxygen to breathe. Very easy to return the alveolar PO2 and therefore the arterial PO2 to the normal value in a patient who is hypoventilating by giving oxygen. Relatively easy thing to do. Okay, now let's move on and look at the causes of hypoventilation. Now I'm not going to go into this in detail because this really is I would if I was giving a lecture in clinical medicine, but I'm not. But let's look at how we would classify the causes of hypoventilation. If someone asks you, well, what are the causes of hypoventilation? This is the thought processes that I would go through. First of all, you could have mischief in the respiratory centers. Now, we haven't dealt with those yet. We will when we come to the control of ventilation, but ventilation is controlled by centers in the brain stem. And so we could have inflammation of the brain, encephalitis, for example, or we could have the action of drugs such as morphine, and they would reduce the level of ventilation. So that would be a cause of hypoventilation. Another cause would be interference with the nerve tracts coming down through the spinal cord. For example, dislocation in the neck and compression of the spinal cord. That would cause hypoventilation because that would remove the impulses going to the nervous impulses controlling the muscles of ventilation, which we'll talk about in a later session here. Then, since the nerves come from the spinal cord through the anterior horn cell, that's where the connection is made, we could have some sort of disease there, such as poliomyelitis. That affects the anterior horn cells. Or we could have a disease of the nerves themselves, some kind of neuritis, all sorts of neuritis. Guillain-Barré disease is one, but there are lots of forms of neuritis, inflammation of the nerves. Or we could have changes in the neuromuscular junction. And there are various drugs that affect the neuromuscular junction. They're used for paralyzing subjects during anesthesia. Or we could have some mischief, some pathology in the muscles themselves, some sort of muscular dystrophy, for example. Or we could have a problem with the chest cage, for example, a crushed chest. If you're involved in a car accident and you bang your chest against the steering wheel, you might get a fracture of the ribs, that's a crushed chest, and that can cause hypoventilation. And finally, you may have obstruction to the upper respiratory tract here, the trachea in this case, caused by, for example, a cancer or something like that, enlarged lymph nodes compressing the airway. So there are all sorts of causes of hypoventilation, as you can see. The important thing, one of the important things here is that all these causes do not affect the lung itself. And that's often the case with hypoventilation. If you can get rid of the underlying cause, there's nothing wrong with the lung. And if you can restore the ventilation, then gas exchange is restored to normal. So that's hypoventilation. It's a relatively simple cause of hypoxemia, but it's important to go through it and fully understand it because it's a common condition. Those of you who go on to become medical doctors and are in the emergency room late at night, you may have a patient come in with hypoventilation caused by a drug overdose, for example. And it's important to understand what's going on. Of course, you would give that patient oxygen and quickly you can restore the PO2 to normal, the arterial PO2 to normal, but the only way you can restore the PCO2 to normal is by increasing the ventilation. Okay, now let's move on to the next cause of hypoxemia, and that is that we have been assuming up till now that the PO2 in the arterial blood is the same as that in the alveolar gas. And that was the assumption we made in the perfect lung. But that is not always the case, and here we see the first step in the diffusion cascade, and that is the change from the end capillary PO2 to the arterial blood. And here's the step here from the alveolar gas to the blood at the end of the capillary here. Incidentally, I meant to mention, I'll do it right now, is that I did mention, of course, that the PO2 in the tissues is much lower. What I should have just added is that although in our perfect lung we've shown a single line for the tissues, of course this is an oversimplification. The various tissues of the body have different PO2 values, they have different oxygen consumptions, they have different oxygen different delivery of oxygen and so on. So the tissue PO2 varies throughout the body. And furthermore, the PO2 of the mitochondria is probably much lower than shown here. It's probably 2 or 3 millimeters of mercury, something like that. But nevertheless, the important fact is that if we interfere with this lifeline, this cascade of oxygen from the inspired air to the mitochondria, any fall in the PO2, any interference with the oxygen cascade has to result in a fall in tissue PO2, other things being equal. So it's useful to remember that there is a tissue PO2, although its actual value this is not a clear indication of its actual value. Okay, so let's talk about diffusion now, and what we've said is that if there is diffusion impairment, there is a fall in PO2 from the alveolar gas to the end capillary blood. That would be diffusion impairment. Now, we don't have to spend a lot of time on this because we've already had a session on diffusion. Nevertheless, it doesn't hurt to just review very briefly what we talked about there. You remember what we said was, in the normal lung, breathing air, where the alveolar PO2 is 100, the blood comes into the lung through the pulmonary artery. The mixed venous blood has a PO2 of about 40. Under normal conditions, it rises very quickly in the pulmonary capillary and has plenty of time to equilibrate with the alveolar gas. Remember, the time spent in the pulmonary capillary is, we believe, at rest about 3/4 of a second. So not much time, things are happening pretty fast, but nevertheless, there's plenty of time for oxygenation at rest in the normal lung. You remember that there are 3 ways of challenging, if you like, this diffusion process. The first way is exercise, because with exercise you reduce the contact time, the time spent by the blood in the capillary. That's because the cardiac output rises from 5 or 6 liters per minute to perhaps 25 or maybe even 30 liters per minute. And so the amount of time that the blood spends in the capillary is greatly reduced. And it may be reduced to, say, 1/3 of a second. Under these conditions, there's perhaps only just enough time for equilibration to occur. As a matter of fact, we believe that some elite athletes at extremely high levels of exercise can show a minor degree of diffusion impairment just because the contact time is reduced. In other words, but that only occurs under exceptional conditions at very high levels of exercise. And you know, this is what you would expect from evolution. Evolution covers all the problems that we're likely to be faced with, but with one or two exceptions for the people at the very far end of the distribution. So that's the first way we can challenge the diffusion process, by exercise reducing the contact time. The second way, you remember, was to go to high altitude or give a patient a low oxygen mixture and reduce the alveolar PO2 from 100 to say 50 millimeters of mercury. And under those conditions, you may have diffusion limitation, particularly on exercise. And the best situation, if you want to demonstrate diffusion limitation in the normal lung, is to take someone to high altitude and have him exercise hard. Then he will show diffusion limitation. And incidentally, the reason for that is a little bit complicated. Sometimes we think of it as simply because we've reduced the partial pressure difference between the alveolar gas and the blood, and of course we've done that, but actually the reason is that we're working on a very steep part of the oxygen dissociation curve, and that's responsible for the diffusion limitation. So that's the second cause. The third cause is an abnormal lung, where we thicken the blood-gas barrier. And of course, Fick's law of diffusion says that if you thicken the diffusion barrier, then diffusion is going to be impaired across it. It's going to be much slower, and therefore the rise of PO2 in the capillary is much slower, and therefore we can get diffusion limitation. And incidentally, if you want to know whether diffusion limitation occurs or not, what you do is you look at the difference between the alveolar PO2 and the end capillary PO2. If there's no difference, there's no diffusion limitation, but if there is a difference, as shown here, there is diffusion limitation. So what kind of lung would do that? Well, we've seen this before. This is the lung of a patient with interstitial fibrosis. These are the alveolar walls here, and you can see they're grossly thickened. Matter of fact, it's not easy to find the capillaries. Here's one, here's another one here. The wall is thickened because fibrous tissue, type 1 collagen, is laid down in the alveolar wall. And it thickens the wall and also, incidentally, obliterates many of the capillaries. So under these conditions, you can expect diffusion impairment. And a patient like this who has hypoxemia, you might expect that the arterial PO2 would fall even further with exercise, and that is often the case. I will add, though, that even these patients with gross thickening of the blood-gas barrier and who have hypoxemia, an abnormally low PO2 in the arterial blood, in these patients, the main cause is actually not diffusion limitation. You may think it would be from a picture like this, but actually the main cause turns out to be ventilation-perfusion inequality, which is a subject we're going to talk about in the next session. Even in these patients, ventilation-perfusion inequality is almost always the main cause at rest, although diffusion impairment can certainly occur on exercise, but it's usually not the primary cause of the impaired gas exchange. Okay, so that's diffusion, and we've talked about that in a previous session, and it's not a particularly difficult subject, and so that shouldn't be a big problem. The third cause of hypoxemia is what's called shunt. Now, shunt is defined as blood reaching the arterial system without going through ventilated areas of the lung. Okay? In other words, there is always some blood that finds its way into the arterial system and has not gone through the gas exchanging tissue of the lung. And even in the normal lung, there's a small amount of shunt. Now, on this diagram, you see it's shown here. Here we've got some shunted blood coming in, doesn't show from where, but some shunted blood coming in, and therefore there is an additional drop in PO2 between the end capillary blood here and the arterial blood. Okay, so that's the contribution caused by shunt. Now, it turns out that even under normal conditions, there is a small amount of shunted blood. For example, you recall that we mentioned briefly the bronchial circulation, because what we're dealing with here is the pulmonary circulation. The blood comes from the pulmonary artery, returns to the heart through the pulmonary veins, but there's also, you recall, a small bronchial circulation. The bronchial arteries come off the aorta, or sometimes an intercostal artery, and they're very small, but they perfuse the larger airways in the lung. Of course, the parenchyma, the gas-exchanging tissue, doesn't need an additional source of blood supply. It's got plenty of blood from the pulmonary circulation. But the large airways, the airways that constitute the conducting airways, the dead space, they require some blood for nutrition, and that blood comes from the bronchial arteries. It's a very small proportion of the total blood flow to the lung, minute, but nevertheless it's there. And most of the blood from the bronchial arteries drains into the capillaries upstream or drains into the pulmonary circulation upstream of the capillaries, or it drains into one of the other veins, the azygous vein or whatever, that goes into the right ventricle. So most of the venous blood from the bronchial arteries is oxygenated, eventually goes through the gas-exchanging parts of the lung. However, there's always a small amount that enters the pulmonary circulation downstream of the pulmonary capillaries. And since that bronchial arterial blood, has been depleted of oxygen because it's given it up to the large airways, at least part of it, the oxygen level in the bronchial venous blood is going to be reduced, and therefore it's going to depress slightly the PO2 in the arterial blood. So the bronchial venous blood is one source in the normal situation of a shunt. There's another source, and these are the so-called Thebesian veins. Now, the Thebesian veins are found in the myocardium. Most of the blood in the myocardium drains back to the right atrium through the coronary sinus. So the vast majority of it does. And incidentally, the PO2 in the coronary venous blood is quite low. The myocardium extracts a large amount of oxygen from the arterial blood, from the coronary arterial blood. But there are a few veins called the Thebesian veins that drain directly from the myocardium into the left ventricle. Very small amount of flow, but nevertheless, that blood, of course, is depleted to a large extent of oxygen and therefore contributes to a fall in the PO2 of the arterial blood. And under normal circumstances, the fall in PO2 caused by a shunt is of the order of maybe 4 or 5 millimeters of mercury. That's a very small reduction in PO2. It's hardly measurable, just measure it, but it's a relatively small fall in PO2. For example, the changes in arterial PO2 with aging are larger than that. So it's a relatively small fall, but we should be familiar with it. Now, there are a number of diseases where shunt becomes extremely important. And one of these is the so-called arterial venous anastomosis in the lung, AV anastomoses. Now, this is a congenital defect where one of the branches of the pulmonary artery drains directly into a branch of the pulmonary vein. Now, of course, under those conditions, the mixed venous blood is getting into the arterial system, and obviously it's going to depress the PO2. So that's one cause, the arterial venous fistula. Sometimes, incidentally, you can pick this up by listening over the fistula with a stethoscope, and you can hear the hum of the blood as it's going, because it's going very fast, through this abnormal anastomosis. And those patients often have other changes in the circulation as well. It's a congenital problem. Another source, if you wanted to find patients with severe degrees of shunt, you would head for the pediatric ward, where the babies who have been born with an abnormal communication in their heart are being nursed. These are the so-called blue babies, okay? And you can have an abnormal communication between the right and the left sides of the heart. You can have a patent ductus arteriosus. Normally it closes at birth, sometimes it remains open. You can have a hole between the two ventricles, intraventricular septal defect, or a hole between the two atria, between the right and left atrium. So under those conditions, you can get a shunt. Now normally, in a patient like that, the shunt would be from the left to the right sides of the heart because the pressures on the left side are higher than the pressures on the right. But sometimes the pressures on the right side increased, and I'm certainly not going into the pathology of all this, sometimes the pressures on the right side of the heart increase. Under those conditions, you can get mixed venous blood, or certainly venous blood, moving across from the right ventricle to the left, or the right atrium to the left, or from the pulmonary artery to the aorta through the patent ductus arteriosus. So those patients can have very large shunts and can have extreme reductions in their arterial PO2 as a result of the shunted blood. Often those defects can be repaired by surgery, and that's one of the important areas of pediatric or neonatal surgery where you can repair the abnormality in the heart. Now, sometimes we can calculate the amount of shunt by looking at the concentrations of oxygen in different places. And here's a cartoon showing a shunt. Now here we've got the blood coming into the pulmonary artery. This QT is the total pulmonary blood flow coming into the pulmonary artery here. And the concentration of oxygen in the mixed venous blood is C for concentration. Mixed venous, we put V with a little bar over it. That means mixed venous. And then oxygen here. So that's the amount of oxygen coming into the lung is QT times CVO2, as you can see. Now the shunted blood, indicated by Q.S, the shunted blood, of course contains the same oxygen concentration of the blood as the mixed venous blood. The blood that passes through the gas exchanging regions of the lung, of course, is well oxygenated, and therefore the concentration of oxygen in the N capillary blood, we put a small c for capillary and a little thing on the end there indicating N capillary. So we have, and normally that has a normal oxygen concentration, because most of these patients with a shunt have a normal lung, and therefore they have a normal alveolar PO2, and therefore the concentration of oxygen in the N capillary blood is normal. No reason to expect a problem in the lung. And therefore you've got the mixed blood, the QT here, the total blood flow coming out, and you've got the oxygen concentration. Now we can write an equation, and we've got the end result up here, but I'm going to show you on the next slide. We can write an equation for the addition of the shunted blood to the non-shunted blood. And this looks formidable at first, but it's not really. It's just the addition of the two circulations. All we're saying is that the total blood flow times the arterial oxygen concentration, that's what coming out of the lung, is equal to the contribution from the shunt, which is Q.S, times the concentration of oxygen in the mixed venous blood, which is in the shunt, plus the rest of the blood flow, QT minus QS, times the concentration of oxygen in the N capillary blood. And that allows us then to write this shunt equation here. We're just rearranging the equation. I'm not going to go through the algebra, it's just rearranging the equation, and you can see it here. Now this is a useful equation because sometimes when the shunt is caused by the addition of mixed venous blood to the arterial blood, we can calculate the degree of shunt, and sometimes that's useful to, for example, a surgeon who wants to know how big the shunt is. He's going to work out what kind of operation he's going to do, and he'd like to know how big the shunt is. So we can calculate it using this. It's not all that easy to do, because to get the concentration of oxygen in the mixed venous blood, we've got to have a catheter in the pulmonary artery. And so that's done at cardiac catheterization, or sometimes it's possible to float a catheter into the pulmonary artery, so-called Swan-Ganz catheter. But you do need to take a sample from the pulmonary artery if you want the true mixed venous blood level. Not difficult to get the concentration of oxygen in arterial blood. You simply put a needle into an artery, brachial artery or radial artery, take out a sample of blood, and you can measure the arterial oxygen concentration. What about the concentration in the capillary blood and the end capillary blood? Well, you can't measure that. There's no way you can put a catheter into the end of a capillary, but you can calculate it because, as I said, in most of these patients, the lung itself is normal, the PO2 is normal, or you can measure it actually from expired gas, and knowing the alveolar PO2 and knowing the hemoglobin concentration, and we could calculate, right? We looked at that in an earlier session. We can calculate, if we know the alveolar PO2, hemoglobin saturation, and the oxygen saturation, we can calculate the concentration of oxygen. So we assume here that the saturation will be normal, 97, 98%, so we can easily calculate the end capillary CO2. So that's a useful equation. Now, sometimes a shunt is not caused by the addition of mixed venous blood to the arterial blood, but by some other kind of blood. I mean, in an arterial venous anastomosis, it'll be the mixed venous blood, but if the shunt is between the two ventricles, then we can't assume that the blood going across from the right ventricle to the left is the true mixed venous blood. It will be close, but it's not exactly so. But we often calculate what we can call an as-if shunt. In other words, what the size of the shunt would have been if the shunt was caused by true mixed venous blood. And that's sometimes done, and that's sometimes useful. Now, there's an important feature of patients who have a shunt, and I'm going to go into that briefly now because sometimes it causes a problem with some people. And this is the fact that if you give a patient with a shunt 100% oxygen to breathe, the arterial PO2 does not rise to the expected level. Now, shunt is the only cause of hypoxemia where this is a fact. It's true that in patients with severe lung disease, chronic obstructive pulmonary disease with severe ventilation perfusion inequality, it might take some time for the PO2 to rise to the expected level or near to the expected level, but eventually this will happen. It's only in shunt that the PO2 does not rise, the arterial PO2 does not rise to the expected level when 100% oxygen is given to the patient, and I'm going to explain why. But first, let me just note that it's not easy to give 100% oxygen to a patient. It's no good using nasal cannulas or putting a mask over the nose or something like that. You're not going to get 100% that way because there are too many leaks. So what you have to do is give the patient a mouthpiece to breathe through, put a clip over his nose, and then you can be certain that he's receiving 100% oxygen. So that it can be done, but you have to do it carefully. Well, now let's look at this diagram here. This red line shows what we've labeled as the oxygen dissociation curve. As a matter of fact, that's not absolutely accurate. The oxygen dissociation curve is the true term is the true oxygen dissociation curve is the oxygen saturation against PO2. See, we've got PO2 along here. We're plotting oxygen concentration, and that's similar, except that, of course, here we're including the dissolved oxygen. Okay, so this is the oxygen concentration shown here against the PO2. Now you may say, well, that's a pretty funny shape for an oxygen dissociation curve. I don't remember ever seeing one like that. The reason is that we've taken it up to a very high PO2. Okay, so normally we plot the dissociation curve from, say, 0 to 100 millimeters of mercury. Here we're plotting it from 0 to over 600 millimeters of mercury. And we're doing that because when we give a patient 100% oxygen to breathe, we can, in a normal lung, we can raise the PO2 in the alveolar gas to well over 600, and we can raise, therefore, the arterial PO2 to certainly 600 or more. So when we look at this curve of oxygen concentration against PO2, what we see is the normal dissociation curve shape, the S shape, up to a PO2 of, 200 or so, and after that, the curve is straight, okay, with a small rise in oxygen concentration as the PO2 is increased. What's the slope of this line? Who can tell me? Well, it's the slope caused by the dissolved oxygen. In other words, it's 0.003 mils per deciliter per millimeter of mercury. Remember, the oxygen solubility was 0.003 mils per deciliter per millimeter of mercury. So the slope of this line is simply given by the dissolved oxygen. Okay, so what happens if we have a shunt? Well, first of all, and we give somebody 100% oxygen. Well, the PO2 in the alveolar gas is going to be very high. As a matter of fact, it's going to be, if we wash out all the nitrogen, the PO2 in the alveolar gas is going to be 760 minus 47, because you've got the water vapor there, minus the PCO2, which if the patient has a normal ventilation is about 40, and that's that, because there's no nitrogen left in the alveolar gas, so that gives us a very high alveolar PO2, okay? So that high PO2 is going to be essentially in the N capillary blood as well. So what we're showing here is the oxygen, the curve here, the red curve, with the alveolar PO2 and the N capillary PO2 right up here. However, when we go to the arterial blood, which contains some of the shunted blood, the PO2 is going to be reduced. Now, how far is the PO2 going to be reduced? Now, here we've got to be careful. We're going to add shunted blood to normal N capillary blood. We mustn't add PO2s. That's a terrible mistake. What we add is the oxygen concentrations, because the oxygen concentration is basically the number of oxygen molecules in the blood. That's what the oxygen concentration really is. So we add oxygen concentrations, and we must be very careful not to think about PO2 here, adding PO2. That doesn't make any sense at all. So we add the oxygen concentration, and what we find is that there is a small decrement in the oxygen concentration as a result of this shunted blood that we've added. Okay, the shunted blood has a low oxygen concentration, so when it's added, the oxygen concentration is reduced a relatively small amount. So this shows the fall in the oxygen concentration. It's not very much, as you can see. This is the fall in the oxygen concentration caused by the shunted blood. But look at the fall in the PO2. It's dramatic. And that's because this curve is almost flat. It has a very shallow slope in this upper part. So although the fall in oxygen concentration caused by the shunt is not very great, the fall in PO2 is tremendous. So in this particular example, the PO2 of the arterial blood here is going to be, I don't know what that is, it's certainly less than 100, whatever it is, between 50 and 100. So isn't that striking? With a relatively small shunt, this patient, if given 100% oxygen, shows an arterial PO2 which is way below what you would expect in the normal lung. And as I said before, it's only shunt, only that third cause of hypoxemia that's responsible for this behavior. And this makes it important in practice. Often in the pulmonary function laboratory, we want to know whether a patient's got a shunt or not. We're faced with a patient with hypoxemia. There are 4 causes, and we're trying to work out what the cause is, because that's going to determine, of course, how we manage, how we treat the patient. So we're trying to work out what the cause is. One of the things we can do is give the patient 100% oxygen to breathe, and that tells us then whether a shunt is present or not. If the PO2 rises to the expected level, you can rule out shunt. Okay, so let's summarize then some of the main points we've made in this lecture. First of all, we started by saying that the primary function of the lung is gas exchange. We started right at the beginning, you remember, by pointing out that the critical thing is the blood-gas barrier, because gas exchange is what the lung is for. And so now we're talking about this, the central issue, central function of the lung, so it's very important. It's also very important, quite apart from understanding the physiology, it's very important in clinical medicine, because many patients, most of the patients, I dare say, with lung disease have impaired gas exchange. And sometimes it's not easy to sort out what's responsible for it, and therefore it's a very important topic. It's so important that we're going to devote 2 sessions to it. In this session, we've looked at the overall cascade of oxygen from the air to the mitochondria, and we've looked at 3 of the 4 causes of hypoxemia. We've looked at hypoventilation, diffusion limitation, and shunt. And we're going to look at the 4th cause in the next session, because it's by far the most important, it's by far the most difficult to understand, and there's a lot of misunderstanding about it, and so it's important to be clear. We looked at the perfect lung, where we can assume that the arterial PO2 is the same as the alveolar value, although the tissue value, of course, is much lower, the tissue PO2. But we made the point that the alveolar PO2 is way below the inspired value. We've lost about 1/3 of the available PO2 by the time we get to the alveolar gas. And we pointed out that if you're an engineer with a power station, that would be very bad news if you lost 1/3 of the available energy along the way, along the pipes leading to the power station. So because of the reciprocal nature of ventilation in the mammalian lung, that's what's responsible for it, the alveolar PO2 is way below the inspired value, and therefore the PO2 to which the capillaries are exposed is way below the inspired value. We pointed out that the alveolar PO2 is determined by these 2 opposing processes: the addition of oxygen by alveolar ventilation, the removal by the blood flow, and that the removal by the blood flow at rest doesn't change much, because the oxygen consumption is determined by the metabolism of the peripheral tissues and nothing to do with the lung. And so generally speaking, the oxygen consumption and the CO2 production are essentially normal. We asked the question of how we can calculate the increase in PCO2 with hypoventilation, and we brought in the alveolar ventilation equation, very important equation, which indicates that there is a reciprocal relationship between the alveolar ventilation and the alveolar PCO2. We then asked the question, what happens to the alveolar PO2 with hypoventilation, and that brought us to introduce the alveolar gas equation. Rather formidable at first, but we're going to use it a lot, so get used to it. It's not a particularly difficult equation, and we used it to show how the normal alveolar PO2 comes out to be 100, and we also used it for a nice little problem, and that is, how do you return the alveolar PO2 to its normal value in the face of hypoventilation? Remember, we were able to calculate that. So that was hypoventilation. We also summarized the causes, or we looked at a way of classifying the causes of hypoventilation, starting at the brainstem and going all the way to the lung and the major airways, and pointed out, by the way, that in almost all causes of hypoventilation, the lung itself is normal. It's something outside the lung which is reducing the ventilation. And so the prognosis, if you can get rid of the cause of the hypoventilation, prognosis is usually very good. We then went on to the second cause of hypoxemia, diffusion limitation. And we could deal with that fairly quickly because we talked about diffusion earlier on. We just reminded ourselves that there are 3 ways of challenging the diffusion process. One is exercise, which reduces the contact time available for the oxygen to load. The second was going to high altitude and reducing the alveolar PO2. And we pointed out, if you really want to show diffusion limitation in the normal lung, go to high altitude and exercise as hard as you can. And then we also mentioned that in disease, in interstitial fibrosis, for example, you get thickening of the blood-gas barrier, which of course interferes with diffusion. But the normal lung, under most normal conditions, the normal lung doesn't have a problem with diffusion. We then went on to talk about shunt and pointed out that even in the normal lung, there are some sources of shunt. There's the blood from the bronchial circulation, some of which, a small amount, finds its way into the pulmonary capillaries downstream, finds its way into the pulmonary circulation downstream of the capillaries. And there's also the Thebesian veins, which drain directly from the myocardium into the cavity of the left ventricle. Not a lot of blood, but a small amount. And of course that depresses the arterial PO2. We looked at the shunt equation, which is simply adding up the amounts of oxygen in the shunted blood and the non-shunted blood to find out how much is in the arterial blood. Quite a simple equation, looks complicated initially, and is useful for calculating the amount of shunt. And finally, we dealt with the interesting problem of what happens to the arterial PO2 in a patient with shunt if you give 100% oxygen. And we made the point that the only cause of hypoxemia where the arterial PO2 does not rise to the expected value is shunt. So it's a useful test in the clinical situation. So those are three causes of hypoxemia. Next time we're going to look at the fourth cause. You'll have to buckle your seatbelts because it's a fairly difficult problem. We're going to go through it slowly, and I look forward to seeing you there. Bye for now.